My name's Jodie Long. I'm the CEO of the Council of Presidents of Medical Colleges, also known as CPMC. I've been the CEO here since March this year, and prior to that, my background's always been in allied health. I started out as a radiographer, but most recently I've held the CEO role at Speech Pathology Australia, and then prior to that I was CEO at the Australasian Sonographers Association. So CPMC is the peak body that represents all 16 specialist medical colleges, and really it helps support them in their mission around providing great medical education and training and ensuring that we have really high quality standards. And that really goes into our purpose, which is to ensure that every Australian, regardless of their postcode, that they would have access to the highest quality specialist care. And we do that by liaising and advocating with jurisdictions across the country, different health departments and different key stakeholders. We're in a specialist workforce crisis at the moment. We have estimated a shortfall of 5,000 specialists by 2030. And the Australian Institute of Health and Welfare has estimated that 22% of the population is going to be over the age of 65 by 2056. And that just means the demand for specialists is going to increase astronomically. Because of this, CPMC needs to be agile, it needs to be responsive, and it needs to be ensuring that it can be participating in conversations in real time. So the previous governance structure that we had at CPMC was that it was a single council which acted as the board, and we had 16 board directors. This was very slow and very cumbersome, and it made decision making quite difficult. So I'm really happy to say that on the 17th of July, we had a special general meeting, and unanimously we decided that we would shift to a council which is truly representative of all the colleges. So there are 16 seats on the council, one from every college, and then we have a separate board function. So what that enables us to do is that the governance and the managing and running of CPMC can be separate, and that's the board function. And then we have the opportunity to really harness 16 voices around the table to really address some of these national issues, as I mentioned, the workforce crisis that we're facing, and really get momentum on trying to create some system-wide changes. It's really important that CPMC is seen as the trusted advisor and the single voice, and this governance structure will allow us to do just that. All 16 colleges have uniqueness. However, all of them have similarities as well. And so we recognise the diversity across our membership. Each college will advocate for things that affect them individually, and they will continue to do so. Having CPMC as the single voice across system-wide issues is particularly important in enabling us to have a seat at the table. The change is that we will have a separate board that governs the organisation, and we will have a separate council. And the council is the representation of all of the 16 colleges and allows us to gather intel and their views on things that are happening within the health sector and things that are affecting them, gather their voice, and then go to government and to politicians with a single voice and have a seat at the table representing all 16 colleges so that we can make their voice heard. Unfortunately, our rural and remote communities have different health equity compared to their city counterparts. If you live in a remote area, you are 2.5 times more likely to have hospitalisation. You also have a higher mortality from preventative diseases. In New South Wales, in rural areas, 40% cannot access specialist care within the clinically recommended timeframes. To give you some practical examples of this, pregnant women are having to travel long distances in labour to access their maternity care. You have farmers who are delaying seeing a cardiologist for their heart because they have to travel for hundreds of kilometres and perhaps spend the night and they don't want to leave their property. Children in these areas are having to travel long distances to get care that they need if they're having learning difficulties. So what is causing this? It's the maldistribution of our workforce. So over the last, since 2000, we've had a doubling of medical graduates. And for the last 10 years, it's kind of plateaued at about 3,600 annually. But what hasn't happened at the same time is the increase in the number of specialist training positions. And we now end up with a bottleneck. The training positions, 90% of them are funded by the states, and 10% of them are funded federally through a specialist training program. But in order to plug the maldistribution, what we're utilising is locums, which costs our country about $1.2 billion a year. And we're also bringing over international doctors and graduates. Yes, this is a short-term solution and it helps address the current crisis that we're in. However, it is not sustainable. And what we need to do is we need to be able to grow our own. And we need to look at better ways to be able to ensure that we can have our own medical graduates and then they become specialists and have them based in rural areas. CPMC, along with the 16 medical colleges, have been working to address the rural medical workforce shortage by looking at implementing rural selection criteria into their training placement programs. If you grew up in a rural or remote area, then you are 3 times more likely as a doctor to go and work in a rural area throughout your career. And if you spent about 12 months or more of your medical training located in a rural or remote area, then you are 30 to 40% more likely to stay in that area. There's a saying, train in the bush, stay in the bush. And Jenny May, the Rural Health Commissioner, has said the biggest predictor of whether someone will practice in a rural area are those 2 factors. And that is something that we have tried to address at CPMC with the colleges. So in February this year, the colleges with CPMC and with the Rural Health Commissioner worked on a rural selection implementation program. And I'm so proud of this achievement that we've created something that all colleges have agreed to implement into their training selection. What we've looked at is to include rural origin, which is those people that have either lived there for 10 years or have lived there for 5 years consecutively. And also weighted people who have spent significant time, being that over 12 months, and a higher weighting for 2 years or more of their undergraduate training and medical training in rural centres. This is really, really important to ensure that we can grow our own medical workforce in rural areas. But there's also another element to this, which will be the next phase that we need to work towards, and that is that we need investment in our rural areas to be able to have true regional training hubs. At the moment, the majority of training places occur within metropolitan areas, with them occasionally going out to rural areas. We need to change this and have rural training hubs where the majority of their time is spent in rural areas, with them going into the city areas for additional training. And that investment needs to occur so that we can ensure that every Australian, regardless of their postcode, can have access to that high quality specialist care.